Dear Chair, dear audience, let me present you my PhD work, which is the impact of uterine surgeries on clinical and reproductive health. My name is Lőrincz. I'm a medical doctor and a PhD student at the Department of Obstetrics and Gynecology at Semmelweis University, and my vision are women without postoperative complications after uterine surgery, and my mission, therefore, is to find uterine surgical techniques which lead to the least amount of complications. Right now, I have two ongoing projects, which I will talk about more in detail. The first project is investigating the efficacy and safety of different caesarean section layering techniques. So just to talk a little bit about the background, caesarean section rate continues to rise globally. Right now, it is accounting to more than 1 in 5 of all childbirths. And we see that this number in Europe is even higher. And it is estimated that by 2030, nearly a third of all births will take place via caesarean section. We have to mention the caesarean scar defect, which is an underestimated pathology due to the clinicians' unawareness. And we know that it can be detected in more than 50% of women with a history of caesarean delivery. It can lead to many potential complications, ranging from infertility to placenta-accreta spectrum disorders, placenta previa, scar-ectopic pregnancy, uterine dehiscence, and rupture. Single or double-layer closure remains a topic of debate, and we know that clinical outcomes are lacking. Our aim was to compare the different layering techniques and assess the complications, the complication rate in post-C-section women. Our clinical question was, does double-layer caesarean section closure technique result in a lower incidence of complications compared to single-layer closure? We used the PICO framework to answer this question. Our population were post-C-section women, divided into two categories, with a subsequent pregnancy and those without a subsequent pregnancy. Our intervention was the double-layer closure technique. The comparison was a single-layer closure technique. And as outcomes, we had complications such as the presence of the scar defect or niche, the measurements of the scar defect, the maternal infectious morbidity, and also some procedural details about the caesarean delivery, length of hospitalization, and so on. And we hypothesized that double-layer closure results in a lower incidence of complications compared to single-layer closure technique. We conducted our systematic search in these three main databases with the following search key, and after the full text selection and the citation chasing, we were left with 35 articles. Our first outcome is the caesarean scar defect at 6 weeks follow-up. Here you can see that we compared the double-layer technique with the single-layer technique, and we made subgroups based on whether they used interlocking sutures or not. I mean, locking or non-locking sutures. And as an effective measure, we had the odds ratio, which was 0.95, which means that it was practically slightly more common in the single-layer group, but not in a clinically significant way or a statistically significant way. The next outcome is the caesarean scar defect at 6 to 24 months follow-up. Once again, we have the same subgroups based on whether they used locked or unlocked sutures, and an effective measure is the odds ratio, again with 0.67, which means again that it was more common in the single-layer closure, but not in a clinically relevant way. The next outcome is the uterine dehiscence. And here we have an odds ratio of 0.55, which again, it means that uterine dehiscence was more common in the single-layer group, but not in a statistically significant way, but we see the same tendency in the subgroups as well. So we consider this clinically relevant. And the next outcome I want to mention is the uterine rupture. And again, we have the same intervention and comparison, the same subgroups based on whether they used locked or unlocked sutures, and an odds ratio of 0.62, which means that it was more common in the single layer group without reaching statistical significance, except for the first subgroup where they used locked sutures in both layers. Here we see that the measure is statistically significant also, and we consider this clinically highly relevant. Our study has strengths and limitations. As strengths, we can mention that we were reaching for the highest level of evidence because we included RCTs. We have a high patient number, a rigorous methodology, but as limitations, we have to mention that we not only used RCTs, we also used cohort studies, and that we have a high heterogeneity. So as conclusion, double-layer suture decreases the risk of uterine dehiscence and rupture in subsequent pregnancies. As an implication for practice, we would advise surgeons to use the double-layer technique, providing a safer condition for subsequent pregnancies. And as an implication for research, we think that more RCTs or cohort studies with different subgroups based on parity, previous C-section number is very needed. Here you can see the current status of our article. We submitted to the American Journal of Obstetrics and Gynecology, which is a D1 journal. My second topic is comparing different cervical ripening methods in optimizing neonatal and maternal outcomes. The prevalence of labor induction in Norway increased from around 10% to 26% during the last 2 decades. In pregnancies in gestational weeks 37 and beyond. We know that mechanical methods and chemical agents are widely used to prepare the cervix for labor, but we can associate some drawbacks with every kind of method, like the chemical only ripening can lead to uterine tachysystole. The mechanical methods can prolong the induction to delivery intervals, and the combined approach is believed to have a balanced effect for better outcomes. Our aim is to evaluate the efficacy and safety of combined cervical ripening in improving maternal and neonatal outcomes compared to chemical-only ripening. Our clinical question is, which cervical ripening mode has better neonatal and maternal outcomes or less complications? Our population were patients with a viable singleton fetus and unfavorable cervix undergoing labor induction. The intervention was the mechanical with or without additional chemical ripening, and the comparison was the chemical ripening only. As outcomes, we have maternal and neonatal outcomes, such as frequency of vaginal delivery, induction to delivery interval, indication for cesarean delivery, and neonatal outcomes such as fetal heart rate abnormalities, Apgar scores, or NICU admissions. We hypothesized that the combined technique has better neonatal and maternal outcomes. And we would like to help clinicians in the personalized decision-making. Here you can see our preliminary search key, which consists of 2 domains. The first one is about the labor and the delivery itself, and the second one refers to the methods. This is the status of my second project, and in summary, I would like to say that we submitted the first article in May, and we plan to submit the second one by September this year. I would like to thank you for your attention. With the words of Thomas Berger, the art and science of asking questions is the source of all knowledge. Thank you.
You mentioned the population in your first study with the layers, and how did you assure that you corrected for the number of deliveries? So had you any patients with previous surgeries as well?
No previous uterine surgeries. They were these women were excluded from the studies.
So and I would guess that as with every surgical technique, training curve is important. So the learning curve, particularly in the beginning, usually we would expect that there are more complications, particularly when you do the first surgeries, right? First cesarean sections. So did you have any information in some of these studies about the training and the learning curve of the surgeons performing the cesarean sections?
Yes. I guess in all of the studies, there were experts of the field who are performing cesarean sections every day. So that is what they said in the studies.
And it is always tricky when you have a combined endpoint, right? In your study, why did you? What would be your arguments to choose a combined endpoint? What is the methodologic benefit of that?
For which endpoint are you referring to exactly?
So in your first study,
yeah,
you mentioned the PICO,
yes,
and the outcome was a combined endpoint. So you had a combined outcome, right? You didn't only have as an outcome uterine dehiscence. You had a combined outcome with more endpoints, potential endpoints. What is the statistical argument for that? Why would you choose a combined endpoint and not the most lethal one, for example, uterine rupture only? What was the concept behind that?
Yeah, so we wanted to have multiple outcomes, and we basically set for example, the 6-week the cesarean scar defect at 6 weeks, because we consider that after the first 6 weeks are a very important time to see what happens, and basically, again, we wanted to have multiple data, and we made different analyses.
I've got one more question. So could you tell us what is the definition of a scar defect and how can you examine it?
Yeah, so scar defect, or referred to as niche sometimes, or ismocele, in most of the studies, they define the scar defect as a unechoic area on the ultrasound of at least with a 2 millimeter depth. But this differs in studies because there were also studies where they used only 1 millimeter to define the scar defect. And so basically, also the methods they diagnose this scar defect differ sometimes.
You mentioned, I think, a very important point, that you stratified or evaluated the outcome based on the type, whether it was locked or unlocked suture, so the technique for the suture. Do you also have any information on the type of suture that was used? For example, barbed suture or monofill sutures. Any information on that?
We didn't collect this kind of data. In some studies, they were mentioned, but not in all of them. So we didn't include this in our analysis.
At the strength and limitation section, you emphasize that your strength in this study that you have a high number of observations. Is there any objective measure? What does it mean? High numbers, and what does it low numbers? What? Because your first lab showed only 3 or 4 studies with 15 patients. So subjectively, it was not so high numbers.
Yeah, but for example, on the first outcome, we have, if I'm not mistaken, 900 patients in the analyses, or from 6 to 24 months follow-up, we have 3,600 patients analyzed. So we consider that quite a...
Okay, your supervisor told that, oh, this is nice high numbers. But
generally,
if you want to express or thinking on when I'm able, when I can to express that, okay, the observations to answer the questions quite hard.
So can you repeat the question?
In which situations, or what is the determinant of the sufficient number of observations? So, for example, I want to check a clinical scenario on disease or effect, which is very rare, for example, 1 per 1,000. In this case, probably I need how many observations if I want to see a change on a very rare complication. So there is a rare complication, a surgical complication, which is around 2 per 1,000, and I want to avoid this 2 given the instance this is very, very rare. And I have a good idea, and I have an intervention to prevent it. And how many observations? What is the estimate? How many observations I would to perform to answer the question that this new investigation is okay, this is effective.
Basically,
Just from body, estimate, or just that. So probably in this case, you need see 10,000, 100,000 of patients and an extreme high number of observations to check or to prove the concept that your new treatment or new measure is effective. So it's whether the patients are this sufficient high is dependent on the occurrence of the observed problem or disease. Okay, maybe.
thank you.
One question. What do you think these double layer closure techniques are also better after 2 or more cesarean section? And what's your opinion? Would you close uterus after cesarean section with double layer every time after 2 or 3 cesarean section?
Basically, we didn't have primary cesarean sections in every study. In some studies, there were the second or the third cesarean section, and we also have this result. So I guess for the second one, maybe, and the third one, the second layer works. In my opinion.
So for sure, the better outcomes after the first cesarean section. The closure techniques, the double layer.
Yeah.
So you can say that I'm gonna close it after for sure because it's better. There will be better outcomes in the first cesarean section. But
based on our analysis, I would say so.